Now, as a quick reminder from our ECG basics video, we know how the electrical activity moves through the heart. The SA node, then the AV node, through the His bundle, then the bundle branches and Purkinje fibers. The PR interval here is the whole conduction. So by logic, if this PR interval is prolonged, then there is some kind of block during the funneling of electrical activity. So now, one of the first things you'll see on an ECG is an AV block, prolongation PR interval. However, in severe AV blocks, there may be a non-conducted P wave in which the QRS is not generated by the P wave at all, but in fact the ventricles. Clinically, we divide the AV blocks into two main categories: the AV node diseases and the His Purkinje diseases. The AV node diseases are less severe, and conduction can be improved with exertion from sympathetic activity. The His Purkinje diseases, however, are more dangerous, and they can often progress to complete heart blocks and often require a pacemaker. Now, there are four types of AV blocks. There's type 1, type 2, and type 3. Type 2 is further divided into Mobitz type 1 and Mobitz type 2. Talking about type 1, this has a prolongation of the PR intervals only, as we just saw. Now, a normal PR interval is less than 200 milliseconds, but we can identify all the P waves present on the ECG, and the block is usually in the AV node. Patients using beta blockers or calcium channel blockers, or even well-trained athletes may have first-degree AV block. Athletes at rest have a high parasympathetic nervous system tone, which slows the heart rate, but also slows the AV conduction. This is usually picked up incidentally when an ECG is performed for some other reason. The second-degree heart blocker type 2 is where some P waves are conducted and some are not. In Mobitz type 1 or Wenckebach phenomena, the location of the block is in the AV node, like in the first-degree AV block. But the hallmark is progressive PR prolongation followed by a dropped beat. There's also a feature called grouped beating, where you see QRS complexes closer together, and this differentiates a type 2 AV block from complete heart block. Another feature is that the RR intervals are not regular. In Mobitz type 2, this variant block is usually in the His Purkinje system. In contrast to Mobitz type 1, there is no progressive prolongation of the PR interval. You can see some conductive and some non-conductive P waves. Mobitz type 2 is more dangerous as there is a higher risk of progression to a complete heart block. These are often seen with bundle branch blocks. Moving on to type 3 or third-degree heart block, no impulse conduction from atria to the ventricles, so the atria and ventricles beat independently of each other. The block is usually located in the His Purkinje system. So there are P waves, but none are being conducted to the ventricles. Something else in the ventricles is depolarizing at a much slower rate. Now, you may think that the P waves are conducting them, but we notice that the RR intervals are completely regular, and that's the key to differentiating a type 3 block from a Mobitz type 1 or 2. The RR intervals being completely normal excludes Wenckebach. There is a term that comes up frequently. AV dissociation is used when there is a dissociation between the atrial and ventricular depolarization, but it can be caused by complete heart block and is seen in ventricular tachycardia and other rhythms. In ventricular tachycardia, AV dissociation is a hallmark of ventricular tachycardia and occurs in the absence of a blocked conduction of the atria and ventricles. This is a very fast heart rate with wide QRS complexes, but these are bumps which are P waves coming from the sinus node depolarization, and because it is so fast that sometimes the P waves conduct the QRS complexes, and sometimes when in between the refractory periods, they do not. The sites of AV blocks are especially important, so you should definitely try to remember these. The first-degree heart block is usually located in the AV node. Mobitz type 1 is also located in the AV node. Mobitz type 2, the block is located in the His Purkinje system, and in third degree or complete heart block, it is also located in the His Purkinje system. Now coming now to the causes of heart block. These include drugs, such as beta blockers, calcium channel blockers or digoxin, athletes which have a high vagal tone, fibrosis and sclerosis of the conducting system, and these are all usually treated by pacemakers. Now moving on to bundle branch blocks. Now only if both bundle branches are blocked, this results in an AV block. But if only one is blocked, this does not cause an AV block. This usually presents with a normal PR interval and causes the QRS to be prolonged. What happens in a right bundle branch block is that the right ventricle is not depolarized from the right bundle branch, but the left is depolarized, and then it conducts towards the right. So that is why it is just prolonged. The same occurs for the left bundle branch block. The left myocytes depolarize after the right is depolarized. Now on an ECG, if the V1 QRS complex points up, it is a right bundle branch block. And if the V1 in the QRS complex points downwards, it is a left bundle branch block.